So no shortcut to experience. So I will invite Professor Mahmood Al Hassan. He is Professor of Cardiology at Lady Reading Hospital. Please join us as a panelist. And Professor Ambar Ashraf also. So, sir. So last talk will be by Dr. Jabbar, he is Associate Professor at Lady Reading Hospital. And vascular access, radial or femoral, it matters a lot for the success of any kind of procedure. Dr. Jabbar Ali.
Thank you very much, Professor Muzaffar Saab. वैसे यहाँ पर एक vascular axis should be the first lecture because without vascular axis, radial versus femoral axis, how ultrasound help? I have nothing to disclose. Why radial first? And do we have to abandon safe femoral in the era of radial first? And how to do safe femoral and safe radial using ultrasound? We can come across such anatomy, and we can see the distal aorta is nasty looking, and we can come across a obese patient in the middle one, or we can come across a tortuous iliac and femoral. So in these cases, we have to switch to the radial. But what about अगर हमारे पास radial femoral जो है tortuous भी नहीं है, straight है, patient thick भी नहीं है, obese भी नहीं है, should we not use radial? No, I think yes, again we have to use the radial because there are other advantages of radial, and we will see in the next few slides. It can be a clinical advantage because the radial artery is small and it is superficial and it can be easily compressed, and we know the bleeding is one of the problem during PCI, especially if you are doing acute cases. Patient comfort, as we know, if we are not using the closure devices, so the patient has to lie for 12 or 8 to 12 hours, and short hospital stay, which will reduce the hospital expenses. So what is the evidence that we have? We have a battery of trials like STEMI Radial, Rifles, Sticks, Safari, and Rival Matrix Cost. These all trials were done in acute coronary syndrome, and the STEMI Radial, it includes only the STEMI patient. And all trials shown that radial artery is better over femoral artery regarding non-cabbage related major and minor bleeding. And in Rifle, Sticks, and Safari, there was some mortality benefit as well. This is the meta-analysis, both in acute and elective cases. We can see the radial artery is better over femoral regarding bleeding, both minor and major bleeding complication. And patient comfort, we do have a radial lounge in our hospital as well, where we can see the patient can sit, they can enjoy their coffee and after their procedure, and after 4 to 6 hours they can be discharged. Based on these data, the guidelines were updated in 2021, and it is class 1 to use radial artery in all the acute cases. And it is also reasonable, again class 1 indications, if radial artery is available, we should use it in elective cases as well. Should we abandon safe femoral? I think absolutely not. This is apolitical, absolutely not. The reason, because cross rates from transradial is estimated 4 to 10% due to inability to either we can't access the radial artery or failed radial access due to anatomical issue or tortuosity, etc. Operator experience. In cardiogenic shock and other procedures, complex procedure, we may need a wide bore catheters. Complex PCI needing large bore guide catheter, MCS. Structure heart like TAVI, EVAR, TEVAR. So in these cases, we need a large bore vascular access and femoral is the route to be used. This is one example. We can see there is a radial loop, and those who are familiar with peripheral intervention, this antegrade approach is used for balloon knee intervention. This was one of the case in which there was, it was being tried from radial, but we can see there is hematoma was suspected. We went from femoral, and thanks God there was nothing serious. So, setup for radial artery is very important. We are seeing our fellows and residents, they bend too much, which is not good for their spinal cord, and they will result if the setup is not appropriate in a spinal cord, in spine injury or other musculoskeletal. So there are two types transradial access technique: front wall puncture, which is done if you are using the needle, just like the Cardis one, or if you are using Terumo, we have to do a double puncture. And this is the commercially available radial support, various types. This is the single wall puncture. This is the left distal radial artery that we do it if the right radial is not available, or the patient is cabbage. Sorry, the slides. This is double wall puncture in which we insert the cannula and the stellate is removed, and then guide wire is inserted. How about ultrasound? We have trial that is ROS trial, and it showed that number of attempts were reduced if ultrasound was used. First pulse success was high, and time to access was less with ultrasound use. And there was, especially if there was complex or axis, radial axis, which was defined as if more than 5 minutes or 5 attempts, again, ultrasound was most beneficial. This is how the setup should be used. We should have a screen in the left shoulder, and this is the video, a short video. The ultrasound probe should be held in non-dominant hand, and then it should be started with linear and then rotated anti-clockwise, and once the artery is identified, it can be punctured in the middle. This is very important, how to reduce the radial artery occlusion. Previously, the dose was 50 international unit, but it was gradually, after this trial, it was increased to 100 international unit per kg. How to do safe femoral puncture? We have either we have to use the palpation, use of landmarks, fluoroscopic, ultrasound guided, or hybrid, in which we use ultrasound and fluoroscopy. This was the trial, first trial, in which it was shown that radial artery is ultrasound guided puncture, reduce the time, and there is less hematoma. And as you use the ultrasound more and more, the success rate will increase. This is the number of attempts were reduced. First pulse success was more. There was less venipuncture. Number of arterial puncture was more. Mean time to insertion was less with ultrasound use. Median time to insertion was again less. Hematoma more than 5 centimeters was less. There was less pseudoaneurysm, dissection, access site bleeding, hematoma, and DVT. There were less seen if ultrasound was used for femoral axis. This was the trial which was published and presented last year in TCT EP. Again, it shows that punctures, venipunctures, and first success was more, and routine use of ultrasonography for femoral axis did not reduce the primary areas of bleeding or vascular complication, but ultrasonography did reduce the risk of venipuncture and number of attempts. This is the video, again, how to do femoral puncture ultrasound guided. Again, ultrasound probe should be held in left hand or non-dominant hand. And initially, it should be along the long axis, and then it is rotated anti-clockwise. So for the sake of time, I'll skip the video because it is long. And these are the steps which is shown in these pictures. And don't forget, once you do femoral puncture, to exclude retroperitoneal hematoma or inferior epigastric artery puncture. So transradial artery should be used in any acute coronary syndrome patients, but the operator has to be trained first in non-acute coronary syndrome cases. Contemporary femoral artery, if you're using ultrasound, is safe. Operators should develop proficiency with real-time ultrasound guidance to facilitate vascular access. Thank you very much.
So excellent talks. Now session is open for discussion, and I will love comments from the audience and panelists. So one quick question to General Nasir Samoor is, what is your experience of using the sheathless guide, especially while doing the PCI, bifurcation PCI with the radial access?
A bigger size catheter, particularly more than 6 French, like 7, particularly 7 French. And if there is a bifurcation stenting required, frequently we do these sheathless 7 French catheter from the radial approach.
Okay. So one question to Farhan Tayyab is, if there is a catheter dissection, what is your wire charge, in fact, to navigate the true lumen?
The true lumen. First of all, the sheathless guides. These are available. These are one size bigger than the normal guides. Like if you use a 6 French sheet, then you can use a 7 French guide cat there. And it's a bit tedious to use. One has learned that one has first crossed the wire, then inflate the tip of the guide cat balloon, and then inflate the balloon of the guide cat tip, and then take it down there. So there is no sheet. When at the time of removal again, you have to replace the guide cat with the sheet, and then you can leave it on for a few hours. When the HD is done, then you can remove. Then to know whether if a wire is subintimal or not, once you're doing CTOs, there is a distinct feeling if the wire gets catched into the subintimal space. There is a lot of resistance and elastic resistance. Then it's a free movement of the wire. If the wire is moving freely, it's probably in the lumen. Then you can see it multiple projections, orthogonal views, that the wire is in the central lumen or not. Then if you have any doubt, you can always give a contralateral injection to find out.
Thank you very much. Any question from audience? So here I close this session. Thank you very much, everyone.
Thank you.